I now have as our next presenters the National Council of Women, and I have one spokesperson listed. There may be more, but it's Ms. Ruth Brown, if I have the name correctly. And welcome, please. And if you have a cohort, looks like you do, please identify her too once you get settled in.
Is here Catharine Laidlaw-Sly from Montreal, who is our national president. So she's going to begin the presentation.
Okay. Thank you very much for coming. Bienvenue, and it's your floor.
Thank you. Mr. Romanow and members of the Commission, the National Council of Women of Canada wishes to thank you very much for the opportunity to appear here. We're here on behalf of the National Council of Women of Canada. It's a national organization which has been working to establish consensus on opinions on public policy for over 100 years at the local, provincial and national level. And our aim is to improve conditions of life for women, their families, in their communities where they live. We see them as the owners and the users of Canada's healthcare system. We're proud of our history of advocacy because it goes back, as I've said, over 100 years, and we started with the issue of clean water, we're still there, and pasteurized milk. Now, on the issue of the Canada Health Act, National Council of Women of Canada members strongly support the retention of the Canada Health Act. We believe that access to medical care should be available to Canadians when they need it and should not be dependent on their ability to pay. Public, non-profit administration is important because it is transparently accountable to the Canadian public, as private businesses may not be. In addition, profit dollars will not be removed from the system and directed to shareholders and owners. I'm now asking our health convener, Ruth Brown, to take over and go through our main points.
Thanks. Mr. Chairman, we're very glad to be here to express the views of the National Council. An important point for us is the fact that a national home care program is an essential component of the healthcare system. And as in the case of medical and hospital care, we think that access to home care should not depend on the ability to pay. We need home care in cases where adults or children with disabilities or seniors with chronic conditions or deteriorating health require ongoing support if they're going to continue to live independently. And it's our experience that most people want to live in their own homes as long as they're able to, and it surely makes sense to do this rather than forcing them to move to a long-term care facility where the cost is much greater. Home care, of course, also can make a huge difference to the outcome for patients discharged from hospital. For the lucky ones, family or friends may be able to help out, but for others, there's no such help available. So many discharged patients need a period of continuing care in a convalescent home or at home if they're to recover from the operation or illness or injury which led to their hospitalization in the first place. Another point of importance to us is support for the family caregiver. As an organization which represents many Canadian women, NCWC has been particularly concerned about this situation of the family caregiver. Not always a woman, but often. And if the healthcare system is to be sustainable, we think it has to recognize its reliance on the family caregiver as part of the continuum of care. It's usually a voluntary role that she plays, but it's no less important on that account. And if she is to continue to sustain that role, she needs some supports at the community level, trainings and support for complex tasks, and some respite care. Our members are also concerned about the situation of caregivers employed in the home care system, often, again, though not always women, and often both underpaid and undertrained. The use in some provinces of the tender system in awarding home care contracts and the introduction of for-profit home care agencies has led to increasingly stressful conditions for home care workers. More patients must be squeezed into one day, and continuity of patient care is lost in scheduling, which is driven by the need to make a profit rather than by the needs of the patient. Pharmacare. Our members have called for a national drug insurance plan which would ensure access to all medications prescribed by a physician. In recent years, drug costs grew proportionately faster than any other item on the nation's health bill, from 9% of total health expenditures in 1984 to 14% in 1996. A patchwork of public and private insurance plans helps some Canadians to cover the cost of their drugs, but 15% of the population lacks any type of drug coverage. We need to look at how the cost of necessary prescription drugs can be covered. We also need to look at escalating costs, our own use of drugs, and the role of prolonged patent protection in keeping drug costs so high. NCWC is on record as protesting vigorously in the 1980s against the extension of patent protection. On the question of sustainability, first of all, we need an emphasis on prevention and promotion of healthy lifestyles and an environment which encourages Canadians to take as much responsibility as possible for their own health. I know it's beyond the scope of the Commission, but we want to make the point that we need a recognition by government of the importance of the determinants of good health: adequate housing, proper nutrition, a safe environment, and an adequate income. This year's report card of Campaign 2000 reminds us that the life expectancy of poor children is shorter, and their risk of chronic health problems twice as great as for children who do not grow up poor. Our members would welcome changes to primary care, which would make better use of resources. Greater use of nurse practitioners would free doctors for the tasks only they can do. Midwives can play a useful role in most normal deliveries. Patients may recover faster when the skills of groups such as dietitians and occupational therapists are part of a team approach. We're aware of acute shortages of human resources in the health care field. Doctors, nurses, radiologists, for example. Overstressed workers are leaving to work in other fields or other countries. We need long-term planning to reverse these trends for the recruitment and training and retention of healthcare personnel. We think that practices such as contract hiring and part-time employment need to be re-examined, and that a return to the hiring of more full-time healthcare workers would be a first step. Restrictions and prohibitions on the licensing of healthcare professionals from other provinces or countries also needs to be looked at. Alternative sources of funding. I just want to say briefly that we've never supported user fees as a method of making the healthcare system more sustainable. Studies have shown they deter not so much those who overuse or abuse healthcare services as those with lower incomes. They discriminate against the less well-off and are likely to deter individuals from seeking medical attention as promptly as they should. We've also been opposed to the establishment of for-profit hospitals and clinics. They raise questions about conflict of interest if they're owned even in part by health practitioners. And as the president of the Canadian Nurses Association noted recently, they tend to siphon off doctors and more easily treatable patients, leaving the financial burden of more complex care to the public system. And there also has been some evidence in recent studies that for-profit care is in general more expensive and creates unequal access. As a women's organization, we'd also like to point out that equity and fairness in the health services require looking at research and treatment through the lens of gender. Studies have shown that research based on clinical studies of males only, as so often been the case in the past, sometimes does not apply equally to women. I turn back to Catharine again.
Right, thank you, Ruth. In particular, bearing on the HIV/AIDS question, Ruth's quite right. The other thing is women have not had equal access to clinical trials and programs, but at present, they are accounting for the largest percentage increase of new cases in Canada, if the statistics we read are true. The last point we want to make is that National Council members believe strongly that the Government of Canada and the governments of all the provinces and territories must work together to provide health care services. Federal leadership needs to be recognized by the provinces, and the provincial responsibilities need to be accepted and accounted for in all planning, so that they are responsive to their citizens and to the makeup of that particular province. In closing, National Council wishes to emphasize these principal points. Home care and family caregiving are usually unpaid work, the unpaid work component of the healthcare system, and the value of this work is not included in the GDP, and yet governments and administrators seem to take that resource as a bottomless pit from which they, or a bottomless supply from which they can always draw, and that it knows no limits. Sustainability is a problem, and Ruth applied to the problem of the turf wars that develop between different specialties. For example, with midwives or nurse practitioners, when they're being added to the system as a means of improving services for patients at a reasonable cost. Mr. Chairman, we firmly believe this issue must be addressed in your recommendations if real improvement is to be achieved. That said, Canada's healthcare system was referred to last Tuesday night on the CBC News after analysis by KPMG as part of the Canadian advantage when it came to attracting new industry to Canada rather than to the States, for example. In other words, it's an asset both socially and economically, so let's keep it working, but better than ever. Thank you very much.
Madam President and Ms. Brown, thank you very much. I like the forceful conclusion, because I've been saying this myself many times, that it's a social and economic advantage. The Chamber of Commerce in Canada was quite receptive to that point of view. So I think more needs to be said to get that message out. And I do want to say that it's not beyond our scope. Maybe it is beyond our scope, but I've appropriated it onto myself in any event to deal with social determinants and the outcomes of health, because the upstream care, water, air, immunization programs, national immunization programs, all these things, good income, education, housing, I think the evidence is just absolutely irrefutable, are probably as important to quality of health and good health as the acute care that we get when we need it. But I do have a couple of questions, if I may, please. First of all, I noted your number one position was, right at the very beginning, don't touch the CHA, Canada Health Act, if I understood you correctly. Mm-hmm. And I'd like to just test you on that. Why would we not want to open up the CHA to add, for example, principles of accountability and transparency? Canadians are saying, I want to know that my taxpayers' dollars, if they're transferred from Ottawa to the provinces, or if they're spent by the provinces, actually go to health care. Or, if you will, to give you another idea, add the notion of patient-centeredness. Try to get the system reoriented by way of a statement of principle, if I can put it that way, that it should be patient-centered. Would these not be good amendments to the Canada Health Act? Or is it your fear that by doing this you opened up a Pandora's box? Or as somebody said in Montreal, the genie is let out of the bottle.
I think that that's the way we would feel, that if we can build that kind of thing in some other way, that and leave the Pandora's box closed.
Is that fear prompted by what? The governance system we have in Canada, federal provincial negotiations,
well,
first
when one
ministers
sees
behind
the
closed
difficulties
doors? Pardon me?
When one sees the difficulties that constitutional conferences have in actually coming to consensus and agreement.
I've never experienced those myself. But
Perhaps this is where the National Council of Women could be of some use, because we've spent over 100 years perfecting the art of finding a consensus.
Well, I believe that, and I accept your offer, and I'm going to be roundly criticized for saying this, but I've often said that when I was in politics in my cabinet, the best the phrase I used was the best men were the women in the cabinet, but what I really meant was the best persons were the women. They knew consensus. But Joking aside, there is an argument that says we should be adding these, and your position is to the CHA that if you do, may be beneficial, but you enter into a very, very unknown field. Just to be absolutely clear about that.
You risk losing.
Well, let me ask just to probe you further, and I'll be probing others as well on this issue if they speak to it. What if we put in a dispute resolution mechanism where there's a dispute, say, between a province and the federal government? For this reason, right now, the interpretation of the CHA is done by Ottawa. It's a federal law. The federal government, rightly so, says we're going to interpret it. Change the federal government, possibly change the interpretation of the law. Thus, some provincial initiative, which heretofore, under the current climate, may be ruled to be in violation of the CHA, could be ruled to be in compliance with the CHA. Would we not have a more solidified, more concretized statement of values by adding a dispute resolution or avoidance mechanism?
That, it seems reasonable.
Yes, Mr. Chairman, I would say it does seem reasonable. And one of the things I can assure you is that a group like ours would certainly, if propositions were being put forward to the public in this light, we would be quite willing to debate it and look at it on its merits. We've not always had everything cast in stone, and we have several years of policy that we don't ever want to see again because we have our viewpoints have evolved. I see no reason why public policy couldn't evolve, but we have always proceeded on these issues with care because they are fraught with so many problems. And the genie could be let out of the bottle. So I think the way in which the debate is framed is going to be a very important part of that, finding that solution.
Then finally, on the question of home care, which was a very major aspect, not the only one, pharmacare as well, but on home care, I was struck by the fact that you called for more education, more respite care, things of that nature. Unless I missed it, I didn't hear a call for tax relief for the actual caregiver. And disproportionately, that caregiver, you're quite right, falls on the females in the family situation. And
actually,
do you say it in your brief?
We did have one other paragraph, and in the interest of time, I didn't actually say it.
Well, I'm not sure the Minister of Finance of Canada wants to hear this, but go ahead anyway. Tell us.
Well, what we've asked for is that that the family caregiver, if she has to leave a job to be a family caregiver, that she be eligible for the same 7-year exemption under the CPP regulations that's now applicable to people staying at home for child care years. And that's something that we've urged the government to consider.
Yeah. That actually is an interesting idea. I heard it the other day in the context of palliative care. Namely something akin to maternal-paternal leave. Now, that may not be a situation in home care where it's a long period of time, but that I find a very interesting proposal. And then to come back to the topic of the questioning today, you don't think that if we opened up the Canada Health Act to include home care as a right that that would be the way to go? You'd want separate parallel legislation and leave the CHA untouched. Is that it?
I think so.
I would think so, too. But again, our members, since we are not currently debating that particular aspect, we might come to a different conclusion.
I appreciate
and again, it would very much depend on how the whole question was framed. I just want to add that one of our very keen interests is the fact that so much of the unpaid, uncounted contribution to the GDP is in the health and caregiving field, and it is not included, and it is not published, and it is not acknowledged, and that is a severe oversight, and it skews the system because we don't really know what the true cost is.
I agree with you on that, too. Thank you very much for a very stimulating presentation.